Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, my name is Mohannad Ibrahim. I'll be discussing imaging of deep neck infections. I have no relevant disclosures. The objective of this talk is to discuss the relevant anatomy and the spread pathways of infections in the neck, and then the imaging features of deep neck infections. Suppurative infections of the neck are uncommon but potentially serious with life-threatening complications. The majority of these infections in pediatric patients are related to tonsillitis and pharyngitis compared to adult patients who have it related to odontogenic infections. Sometimes there is no source for these infections. Approximately half of these infections will occur in the peritonsillar region as peritonsillar abscess, with fewer of these lesions occurring in the retropharyngeal, the submandibular, and the buccal space region. Neck infections progress from focal cellulitis to organized phlegmon to mature abscess. It is important to be able to differentiate a phlegmon, which is pathologically represent an infected tissue without necrosis, from abscess, which is a drainable cavity of infected debris and pus that is walled off by granulation tissues. On imaging, the phlegmon appears as an ill-defined low attenuation region with poorly defined margins compared to the abscess, which has fluid attenuation appearance with an enhancing rim. Management of a phlegmon requires supportive care with hydration and pain management as well as antibiotics compared to the abscess, which will require supportive care, antibiotics, along with surgical drainage. The specificity of CT in predicting the presence of purulent material vary from one study to another, ranging from 45 to 82%. CT is the test of choice in suspected deep neck infection and is necessary to determine the location of the infection and differentiate an abscess from cellulitis. Here we have two different patients who have deep neck infection. The patient on the top have an ill-defined area of low attenuation located posterior to the pharynx, as indicated by the yellow arrow representing a retropharyngeal phlegmon. The second patient on the bottom has an asymmetrically enlarged palatine tonsil with ill-defined area of low attenuation deep to the tonsil, representing tonsillitis with probable peritonsillar phlegmon. Allowing these processes to mature will give it its full appearance, with a first patient having the retropharyngeal abscess as an area of hypodensity with well-defined margins, and the second patient has a peritonsillar abscess with areas of hypodensity deep to the enlarged left palatine tonsil. On this note, let's discuss anatomy of the tonsillar fossa. The palatine tonsils are located within the oropharyngeal isthmus in the tonsillar fossa. They are bordered, and each of the palatine tonsil is bordered anteriorly by the palatoglossus muscle forming the anterior arch, and posteriorly by the palatopharyngeal muscle forming the posterior arch, as seen on the illustrative image. This is also surrounded by the tonsillar capsule. There is a potential space located between the tonsillar capsule and the pharyngeal constrictor muscle, which is the peritonsillar space that is filled with connective and areolar tissues. This space is not seen on imaging as indicated on the axial T2 weighted image of the oropharynx. However, we can easily see the palatine tonsil and the pharyngeal constrictor muscle. A peritonsillar abscess presents itself as a fluid density abnormality with well-defined enhancing rim that is located to the deep palatine tonsil, as seen in this patient. The management of peritonsillar abscess relies on performing surgical drainage either at bedside using needle aspiration or in the operative room with incision and drainage, along with supportive care, hydration, pain management, and IV antibiotics. The majority of these infections occur at the upper pole of the palatine tonsil, which is probably related to the presence of Weber's gland. As seen in this patient, there is evidence of hypodensity at the upper pole of the palatine tonsil, and typically the first site to be drained is in this region. Fewer of these patients will have the abscess located at the mid aspect of the lower pole of the palatine tonsil. Moving to the oral cavity, which is defined superiorly by the hard palate that forms the roof of the oral cavity, and inferiorly by the mylohyoid muscle, which forms its floor. The mylohyoid muscle is a paired muscular sling that extends along the inner aspects of the mandible and have what looks like a cup-shaped appearance. It separates between the sublingual space, which is located superior to the mylohyoid muscle, and the submandibular space, which is located inferior to the mylohyoid muscle, as seen on this coronal T2 image and the illustrative image. Medial spread of suppurative odontogenic infection is facilitated by the relatively thin lingual cortex around the tooth root. This can spread superior to the mylohyoid muscle into the sublingual space, as seen in this patient, where there is evidence of fluid density abnormality with an enhancing rim representing abscess located superior to the mylohyoid muscle within the sublingual space. Or it can spread inferior to the mylohyoid muscle into the submandibular space, as seen in this patient. Odontogenic infection involving the posterior teeth will have preferential spread posteriorly into the masticator space, as seen in this patient, where there's evidence of periapical odontogenic abscess with multiple abscesses within the masticator space. The spread pathways of odontogenic infection in the oral cavity is influenced by the location of the root of the tooth and the arrangement of the muscles and the fascia, which is defined by the direction of the mylohyoid line. This is the insertion site of the mylohyoid muscle, and any of the tooth that has its root located above the mylohyoid line will have preferential spread of the infection into the sublingual space compared to the teeth which has its roots located inferior to the mylohyoid line, which has its infection spreading into the submandibular or the masticator space. Ludwig angina is an aggressive cellulitis of the floor of the mouth that is potentially life-threatening as it results in airway compromise. This is primarily a clinical diagnosis. However, imaging may be helpful to assess the extent of the inflammatory process and then to assess for the presence of underlying dental abscess, as there is approximately 85% concomitant dental infection. These patients present with diffuse edema with soft tissue swelling. As seen in this scout image, there is evidence of abnormal swelling within the oral cavity with bulging of the tissues inferiorly, as seen with fullness in the submandibular region indicated by the arrow. The patient's airways are compromised, and the clinicians has to perform a nasal intubation to establish the airway. On imaging, as seen in these coronal reformatted images, there is evidence of edematous changes throughout the sublingual space indicated by the yellow arrow, which is spreading into the submandibular space as indicated by the white arrow. On axial images seen on the right, we can see inflammation in the sublingual and the submandibular space. The retropharyngeal space extends from the skull base to the superior mediastinum and is situated posterior to the pharynx and esophagus. It is bounded anteriorly by the buccopharyngeal fascia and posteriorly by the alar fascia, as seen on the illustrative image on the right. These fascia will fuse inferiorly within the superior mediastinum at the level between the first and second thoracic vertebrae. A retropharyngeal abscess can present locally with a suppurative infected node, as seen in this patient who has two suppurative infected retropharyngeal nodes representing retropharyngeal abscesses. The management of such patients will require supportive care, hydration, pain management, and IV antibiotics if they are relatively small, less than 2 cm in size. However, sometimes there would be more aggressive spread through the retropharyngeal space, as seen in this patient, with fluid throughout the retropharyngeal space spreading into the superior mediastinum. Managing such patients is more aggressive with surgical drainage. The danger space is located posterior to the retropharyngeal space and is bounded anteriorly by the alar fascia and posteriorly by the prevertebral fascia, as seen in this patient. Infections within the danger space will be located posterior to the pharynx, as seen on this axial and sagittal reformatted image, which spreads inferiorly into the thoracic cavity. So how can we separate and differentiate infections in the danger space from the retropharyngeal space? By the extent of the caudal spread of the infection. Patients with danger space abscess will have the infection posterior to the pharynx and then spreads inferiorly into the thoracic cavity to the level of the diaphragm, compared to patients who has a retropharyngeal abscess, which will have infection posterior to the pharynx. However, its caudal spread will be only to the level of the thoracic cavity around T1, T2 level. Prevertebral abscess infections will also present itself with inflammatory changes posterior to the pharynx. However, these patients will classically have associated discitis osteomyelitis, as seen in this patient, with evidence of C4, C5 discitis osteomyelitis indicated by the yellow arrow and extensive inflammation indicated by on the second image located anterior to the vertebral column. Or it can be related to infection from somewhere else spreading from the mastoid process, where there is evidence of acute mastoiditis with perforation and abscess spreading within the perivertebral and the prevertebral space, as seen in this patient with Bizold abscess. Thank you very much for your attention.